Hello guys, welcome back to A to Z Dentistry, a channel which features easy explanation of various medical and dental related topics. And our today's topic is 10 differentiation points between necrotizing ulcerative gingivitis and necrotizing ulcerative periodontitis. So without any further delay, let's get started. So our first point of differentiation would be on the basis of the definition. So necrotizing ulcerative gingivitis is basically an acute infection which affects the gingiva without any bone involvement, right? So this is the most important point, that it is affecting only the gingiva and not the surrounding structures. So according to Carranza, NUG is a microbial disease of the gingiva in context of an impaired host response, right? So this is the first point that we need to remember. Then it is characterized by necrosis and slowing of the gingival tissue. Second important point, and it presents with characteristic signs and symptoms, right? So first is that it is a infection which is primarily affecting the gingival tissues only, right? So in this figure you can see marginal gingiva is affected, and definitely this part, the attached gingiva, is also affected, right? So two important points, revising again. Impaired host responses is the main culprit here, right? For example, in patients with any underlying disease. And the second is presence of necrosis and slowing of the gingival tissue characterizes our NUG, right? In contrast, NUP is a severe infection, right, which involves gingiva, periodontal structures and the bone, right? So here our NUP is nothing but an extension of NUG itself, right? So in NUG we said that only our gingiva is involved, but here we are saying gingiva plus periodontium plus alveolar bone is involved here, right? So NUP may be an extension of NUG into periodontal structures that leads to periodontal attachment loss and bone loss, right? In this figure you can see marginal gingiva is obviously greatly compromised, it's almost not there. Then we have attached gingiva right here with diffuse erythema. There is an diffuse erythema plus edema. I hope you can appreciate this here, right? So here there is extensive slowing of the gingiva, right? Obviously there is loss of PDL fibers, and plus there is an absence of our junctional epithelium as well, right? See here you can appreciate clear, we can see that there is a bone loss which is present. There is compromised in the quality of attached gingiva as well. Here there is no adequate attached gingiva present, therefore the root of the tooth is also clearly visible over here, right? So these features are characteristic for NUP, right? We have involvement of gingiva plus PDL definitely, plus we have extensive bone loss which is present. Okay, moving on towards our second differentiating point, that is based on the etiology of these diseases. So necrotizing ulcerative gingivitis is associated with stress, right, poor oral hygiene, smoking and marked immune suppression. Very important point here, right? So in situation of stress, right, makes a person vulnerable for NUG, right? Also in patients with very poor oral hygiene, NUG is invariably present, right? Also habits like smoking predisposes a patient to NUG, and immune suppression. Now immune suppression is characteristic of many diseases, right? For example, various lifestyle related disorders such as diabetes, right? Diabetes, number one cause where there is immune suppression which is seen. Then second, for example, cancers, multiple myeloma, acute myeloid leukemia, all these type of cancers wherein the immune suppression is present, NUG may be present in such patients as well. Then for NUP, it is associated with severe cases of immunosuppression. Very important. See, immune suppression is common for both of them, but in cases of severe immune suppression, when the T cell count is very, very less, when the T cell count goes very, very less, in such cases, NUP may be found. Why? Because NUP is nothing but an extension for NUG itself, right? So when NUG is left unchecked, right? When NUG is left untreated and unchecked, it will result in NUG, right? So it is associated with severe immunosuppression, for example, AIDS and HIV, right? Moving on further, our third point of differentiation is based on the tissues which are involved in these diseases. So as we have seen previously, NUG is related and is limited to gingival tissues only, right? So when we talk about gingival tissue, we mean marginal gingiva plus attached gingiva plus our interdental papilla as well. So there is extensive slowing and necrosis of gingival tissues only. Here you can appreciate there is slowing of the gingival tissues which is present, right? So it is limited to the attached gingiva and interdental papilla. Here you can appreciate, see, interdental papilla is also getting involved here. So this is NUG, right, which is limited to gingival tissues, whereas in NUP it will involve, see here, it is not only involving the gingiva but it is also involving the periodontal structures. Here you can see definitely there is loss of the junctional epithelium, or the epithelial attachment is not here, right? Here also you can appreciate there is a complete loss of attachment epithelium over here. It is not present, and there is extensive slowing. There is extensive slowing which is present over here, and also there is a bone loss. Very clearly, clinically you can appreciate there is a bone loss because the root of the tooth is also visible within the oral cavity. See here as well you can appreciate the amount of bone loss which is here, right? There is slowing, and in some of the cases, in very severe cases, the bone might also be exposed into the oral cavity as well, right? So this is the major difference between NUG and NUP. Our fourth differentiating point is based on the attachment loss. So here you can appreciate in cases of NUG, right, there is no loss of attachment. We have already discussed this, right? There is no attachment loss. Relatively, if we see, the clinical picture is much better than in cases of NUP, right? There is no attachment loss because there is no periodontal involvement. We have already seen that all the destructive changes are limited to interdental papilla only, right? So there is no harm or whatsoever to the periodontium, so therefore there is no loss of attachment, and obviously there is no periodontal pocketing which is seen. Whereas in case of NUP, here you can see it is a very severe clinical picture. Here you can see, look at the edema, look at the condition of gingiva, right? It is very, very compromised. Look at the amount of calculus and plaque which is present over here, right? Also take a note that how the roots are exposed. The roots are exposed means there is definitely loss of alveolar bone present over here, plus there is loss of attachment, right? So here there is significant attachment loss and presence of deep periodontal pockets. Obviously you can appreciate, look at the condition, right? Here definitely periodontal pockets are present. Here you can make out the junctional epithelium is greatly compromised, the attachment epithelium is compromised, right? Definitely there is a deepening of the gingival sulcus we can appreciate from this clinical picture. There is significant attachment loss which is present over here, right? And also definitely there is involvement of alveolar bone, right? There is loss of alveolar bone as well. Moving on further, let's try to differentiate nug from nub on the basis of symptoms. So as mentioned previously, right, nub is a severe form of nug, right? So the symptoms will also be very severe in cases of nub when compared to that of nug, right? So in nug we have pain, gingival bleeding, ulceration and metallic taste in the mouth, right? In contrast with that, in cases of nub, the patient will complain of pain, bleeding, halitosis, ulcerations and deep pockets, right? So the differentiating point would be presence of deep periodontal pockets, because here there is involvement of periodontium and bone as well. So here there will be presence of deep pockets, whereas in case of nug there are no pockets, right? So this is very important. In exam you might get an MCQ that in which condition there is extensive amount of periodontium involvement, or in which cases you will see presence of deep pockets. So always remember, in nug there are no periodontal pockets present. It is a very severe disease, yes of course, but then there is no presence of periodontal pockets. Very very important point, you must remember, right? Moving on further, let's differentiate nug from nub on the basis of tooth mobility. So here is a radiograph depicting nug, right? So here you can see bone is intact, right? Bone is intact, interdental bone is intact as well, right? Here you can appreciate there is no loss of alveolar bone height, right? The interdental bone is intact here. So therefore teeth remain stable in cases of nug, because as discussed previously there is no involvement of alveolar bone. Only the gingiva is affected, which is involvement of soft tissue, so no bony changes are seen. Whereas in cases of nub you can appreciate the amount of bone loss. Just look here, right? There is an extensive bone loss. Clearly you can see, right? There is also presence of defect. This is angular bone defect, right? So teeth are in most of the cases mobile because of extensive amount of bone loss. Here as well you can take a note of the bone loss. See the extensive amount of bone loss which is present, right? So this is also a very important feature, right? So on the basis of radiographic changes you can differentiate nug from nub. Also, because in cases of nug there is no bony involvement, the teeth are intact, teeth are stable, there is no mobility. Very important point, there is no mobility, whereas in cases of nub mobility is present, right? Mobility is present. It might be grade 2 or grade 3. In less severe forms it might be grade 1 mobility, but mobility is definitely present in nub and completely absent in nug. Our next point of differentiation between nug and nub would be bone destruction. So here is a radiograph depicting nug. So here you can see the bone is very much intact, right? There is no loss of bone. See here, enough of interdental bone, tooth are very well placed in the socket, right? So there is no bone loss in nug, versus when you look at nub you can see over here there is bone loss, which is clearly seen, clearly demarcated, right, leading to formation of, here you can see it is an angular defect, right? So in case of nug we have no bone loss, and in cases of nub we have significant amount of bone loss. Our eighth differentiating point would be on basis of severity. So as we have seen previously, nug is a less severe form, right? So here you can see only the gingival tissues are involved. Therefore, it is less severe and it primarily affects the marginal gingiva, right? So in stage 1, it will only involve the marginal gingiva. In stage 2, we'll have marginal gingiva plus attached gingiva, and in stage 3, we'll have marginal gingiva, attached gingiva, right? Plus we'll have interdental papilla as well, right? So nug is related to gingiva only, and of that marginal gingiva is primarily affected, whereas in case of nub, as it is a more severe form, right? So tooth loss can be there. Why? Because there is loss of the attachment epithelium, because of loss of periodontal fibers, right? There is loss of PDL fibers here, and also because there is loss of the alveolar bone as well, right? There is significant amount of bone loss, therefore it is more severe and even can result in tooth loss if it is left untreated. Moving on further, our ninth point of differentiation would be radiographic findings in these diseases. So in cases of NUG, either you go with our conventional IOPA or OPG, right? So here you can see there is bone is intact, right? There is no bone loss whatsoever here. Whereas in cases of NUB, there is marked bone loss, right? So here the loss of the bone is a crucial marker for NUB, and it has been mentioned multiple times because you can write this as an SAQ in your paper, right, by giving headings. For example, here I have labeled it as radiological findings. Then also you can mention the same thing under a bone destruction, right, and also under severity of the bone loss, right. This adds points to your answer, and also it is a way we need to write for SAQ because we need to write at least 10 differentiating features. So this is the way you can write this point. So our last point of differentiation is based on the treatment for NUG and NUP. So for treatment of NUG, we need to have scaling and root planing as the first line and the conventional line of treatment, right? It definitely requires scaling and root planing. Apart from that, yes, we need to put the patient on antibiotics as well. Again, amoxicillin plus clavulant is given in most of the cases. Also, we have to ask the patient to maintain a very good oral hygiene, right? So apart from toothbrushing, we also need to counsel the patient regarding use of floss and mouthwash as well. Particularly chlorhexidine mouthwash is very helpful in these cases, right? Whereas in cases of NUP, it requires surgical debridement, right? It is very necessary because there is formation of periodontal pockets and often they require a surgical line of treatment, right? So it requires debridement and surgical interventions as well, right? So as there is bone loss, we need to have bone grafts, right? And also in many of the cases GTR is also indicated, right? Guided tissue regeneration is also necessary apart from bone graft, right? Also you see osseous surgery may also be required in these cases, right? Because the amount of bone destruction is so severe and there is a great irregularity within the contours of the alveolar bone, therefore osseous surgery may also be indicated in many of the cases of NUP, right? So guys, that was all